We're going to move on to you talking about LC-1 fractures. Absolute minefield. Good luck with that.
Great. I always get the good assignments. Well, thanks everybody. Thanks for the invitation. Greetings from the West Coast of Canada. And I was assigned today to talk to you about LC-1 pelvic fractures and highlight where we are in 2021. I do have some disclosures, but none of which pertain directly to the topic we'll be discussing today. Oopsies. Sorry, something happened there. So I'll start with a case. This is a pretty typical case for us in Vancouver. We're directly adjacent to Whistler, which is a world-class ski resort. It attracts a huge volume of visitors every year, and it creates a lot of trauma for us. This was a middle-aged gentleman who had a crash with another skier skiing out at the end of the day. And he suffered a pelvic ring injury that was apparent on the initial AP pelvis, that he had bilateral anterior ring injuries that were pretty minimally displaced. And his axial CT scan showed that he had a complete sacral fracture, but the overall rotational alignment of the pelvis looked pretty good. So what we'll try to work through today is what we're going to do with this gentleman. So the objectives today are that we're going to touch a bit on the history, both of LC-1 pelvic fractures and where we are overall in evidence-based medicine and pelvic fracture treatment. There's some important distinctions to highlight in LC-1 pelvic fractures. And then we're going to get to why decision-making still remains hard. And that involves getting an in-depth look at the literature in the area. Finally, we'll get to the nuts and bolts of treatment. So what are the treatment algorithms that are available and what are the treatment options? And finally, we'll come to future research directions. So first, I think it's important to highlight that pelvic fractures that are bad enough to require surgical treatment have all kinds of long-term disability, and there's lots of different factors that drive this disability, making studying the importance of different treatment methods, this type of screw versus that type of screw, or surgical and non-surgical treatment, makes the study of those things difficult. In our longitudinal study, we found that B fractures or rotationally stable fractures do better than C fractures, but at 5 years, both still have substantial disability compared to baseline. Historical literature in pelvic fractures is fairly low quality by today's standards. In this systematic review we did in 2012, we found that the overwhelming majority of papers in surgical pelvic fractures use radiographic measurement as their primary outcome, but they don't do a great job of it. They don't tell you how they're measuring this many millimeters versus that many millimeters of displacement. They don't test that measurement technique. And there certainly isn't a clear correlation between millimeters of displacement and functional outcome. We've looked more closely at this to test whether experts can actually do that. So if we're being told that 5 millimeters or 10 millimeters of displacement is really important, is that something that we can actually measure? And we found overall previously described techniques have pretty poor reliability, with the possible exception of really simplistic methods in which it's essentially a single line of instructions. So there's no reference line, it's not multi-step. And with this method, that gives you a ratio, which is sort of hard to interpret based on our conventional language. Functional outcome reporting in pelvic fractures really isn't very different. It's been really varied, making comparison between various studies or knowing really how to best measure outcome in our patients difficult. So in a nutshell, the quality of evidence in pelvic fractures really is in its infancy. And we're going to need much higher quality evidence to really have strict treatment guidelines. But we still need to do something with our patients. So we still need to move forward on what the best available information is so we can make a decision. The Young and Burgess classification, which is my personal favorite, was described in the mid-'80s, and they described a mechanistic classification of 3 main fracture subtypes. Lateral compression fractures are those in which the pelvis is infolded from the side. An LC-1 fracture is where the compression failure occurs at the sacrum. LC-2 fracture, it occurs at the ilium. And an LC-3 is either one of those with an open book on the contralateral side or a windswept pelvis. The initial series of these really highlight how they've always been viewed, which is that they're fairly minor. You know, the posterior ligamentous structure is intact, the sacrotuberous and sacrospinous ligaments are intact. And in this initial series, the severity of injury in the sacrum was largely small, so buccal fractures or very minor injuries. But for those of us who run a modern day trauma practice, we know that the spectrum of injury in real time is actually much greater than that. So some patients with lateral compression fractures actually have very high energy injuries. With this in mind, when I was a fellow with Adam Starr, we just wanted to kind of characterize that. So what is the spectrum of bony injuries? How do we categorize those? And how frequently is each subgroup occurring, both in the posterior ring and the anterior ring? And what we found is that we could essentially have three types of anterior sacral injury, either buckles, simple fracture lines at the front of the sacrum and the back of the sacrum, or more comminuted injuries. We called all of those that came through front to back, like our patients, complete sacral fractures. And in this study, we found that half of patients really have this complete sacral fracture, and that's predicted by ISS, zone 2 injuries, and abdominal injuries. So if we can agree that these higher energy lateral compression injuries are common, can we agree on how to treat them? And the short answer to that is no. So in this often cited study where 27 cases of lateral compression injuries were sent to 111 OTA members. So these are trauma surgeons with a pelvis-based practice. They called consensus if more than 90% or less than 10% of respondents wanted to perform surgery, so that the overwhelming majority agreed on that surgery was required or not. And that occurred only in a third of the cases. So only in those most significant and least significant injuries. So in the extremes, maybe treatment is accepted, if not proven, but there's a huge gray area in the middle in which it still remains very unclear what we should be doing. Heather Valier and Paul Ternetta have done a lot of work in this area. In 2019, they published this series of 333 patients from multiple centers with unilateral sacral injuries. The vast majority of these patients had LC-1 fractures, and a third of them were treated surgically. So with all of these decision makers involved, they look back at the radiographic markers that these patients had preoperatively to see if they could determine a pattern in which these decisions are being made. And essentially that pattern is not there. So seemingly fairly random decisions as to whether patients required surgery or not, highlighting the need for some kind of development of consistent indications for treatment. This Bovell award-winning paper from Tornetta's group in 2019 looked at stability with early weight bearing. So they had 118 patients with LC-1 pelvic fractures that were allowed to weight bear immediately. And they found that displacement, how they were measuring it, occurred almost never. So 1 out of 118 displaced and were converted to surgical management. Contrast that with this paper, which was an OTA highlight paper the following year, and they had 117 patients, which again were treated non-surgically based on having less than 5 millimeters of initial displacement. And they found that a particular subtype, so those with complete sacral fractures and bilateral rami fractures, almost always displaced, or 68% of the time they displaced. So clearly, the evidence remains very conflicting. This study from 2014 took 50 patients that were in that gray area. So they had a complete sacral fracture, displaced less than a centimeter. They were all treated non-surgically. And using the Majid score, which can have some issues with ceiling effect, they found that the overwhelming majority had excellent or good outcomes if they didn't have another lower extremity injury. So we can see from this review of the literature why consensus remains so difficult. The next major school of thought around lateral compression pelvic fractures came from Claude Saji and his group. So he's been a big proponent of examining patients under anesthetic. He describes a large series of maneuvers and fluoroscopic views in which he advises acting on any displacement of greater than a centimeter. So this invokes a lot of surgical treatment of pelvic fractures, but he cites 100% negative predictive values. So if you pass the EUA, then you don't have any late displacement. In 2018, with Hassan Mir, they've subsequently published a more involved algorithm for LC-1 specifically, in which they talk about doing an EUA of the posterior pelvic ring. If there's displacement there, then they act on the instability in the posterior pelvic ring and repeat the EUA to look for displacement in the anterior pelvic ring, and similarly address that if it's present. Critics of the EUA algorithms, of which I would put myself in that camp, would say, well, what exactly are you measuring? If we can't reliably measure to within millimeters on a computer screen, can we do it with a moving pelvis on a fluoroscopy screen? How reliable is it? So can two people measure the same thing? And why is a centimeter the cutoff? So is 11 millimeters bad and 9 millimeters is okay? There's never been a demonstrated association with final functional outcome. And then probably most importantly is to think about what the trade-offs are. So this is a resource intensive as far as cost and surgical time, with a potential for complications, including neurologic complications from fixation of the posterior pelvic ring. One of the other main thoughts is around the impact of early surgery on pain and early mobility. In this study of 63 patients, they did EUA with the typical indications. And they had significantly positive findings in the surgical or EUA positive group. Better pain, faster mobilization, faster discharge by several days, and less opioids. So much so that they drew very strong conclusions, recommending surgical treatment for patients with complete sacral fractures without EUA. Others have been unable to reproduce these results, however. So this study from the shock trauma group in 2016 took 158 patients, 51 operative, 107 propensity matched non-operative patients, and they found no difference in pain scores or narcotic use, but a potential difference with faster mobilization. This study, again, by Tornetta and Valier, they looked at 194 patients over 18 centers and looked at the visual analog score for pain in those unilateral sacral fractures treated with surgery versus no surgery. They had a statistically significant pain finding at 24 hours, but that didn't hold significance at the later time points. And it was of what's been brought up as questionable clinical significance. So in the end, what we know is a lot less than what we don't know, but we know that this represents a huge spectrum of injury in which there's little or no consensus on treatment except at either extreme end. Treatment still has an unclear impact on outcome, certainly functional outcome, but there are some potential benefits of surgery, including radiographic, early mobilization, and early pain control. Fragility fractures of the pelvis or low energy lateral compression pelvic fractures in older patients are certainly a different subgroup which requires some consideration. Different spectrum of injury and different patient population than younger, higher energy pelvic fracture patients. These have historically universally been treated non-surgically, but there certainly is proponents that these are a different animal that requires special consideration. Rahman's and his group, so much so that they've described a completely different classification system for these injuries, in which they would support surgical management in almost all, or certainly almost all, that are not weight-bearing 3 days after injury. The evidence in this area is limited, but this is a group that may actually really benefit from early surgical stabilization. None of us would question if the patient with the femoral neck fracture on the right or with the acetabulum fracture with significant protrusio on the left needs surgery. But whether this patient needs surgery remains a major question, although the risks of lack of mobility, including morbidity and mortality in this population, presumably is the same. If we do decide to operate on patients, surgical options include posterior fixation, anterior fixation, or a combination of the two. Percutaneous fixation really is the standard of care now in the posterior pelvic ring. And anterior fixation also can be percutaneous, can be more formal ORAF through an anterior approach, and a distraction X-fix or infix device as well. Mr. Bates asked me specifically to say what I do. So I would say my process is sort of a take on the scoring criteria proposed by Beckman, in which they said anyone who scores 7 to 9 should be considered for surgical stabilization. I don't know if I would put the bar that low, but I would agree that many of the factors described here matter. So initial sacral displacement, location in the sacrum of the injury, how many columns are involved, and the relative displacement and location of injury in the anterior ring. I look at injury factors as well as patient factors, so displacement, radiographic markers of instability. EUA is not a routine part of my protocol or our protocol at our center. Injury severity is an important factor. So whether this patient specifically because of chest injuries or other reasons may have a big mobility benefit from surgical fixation. And we need to always be considering the overall morbidity of the trauma. And rarely there will be a patient who fails conservative management, whether that be radiographically fails in a pronounced way or failure to mobilize. Because I trained in Dallas, Texas, in my hands, that's percutaneous whenever possible. And if needed, the addition of an infix as a secondary option in the anterior pelvic ring. So with all that in mind, that first patient I showed you did have fixation of the posterior ring and not of the anterior ring because of the lack of displacement in the anterior ring. We were aiming for early mobilization and he was having significant pain. He also had some overlap or displacement in the sacrum. So the takeaways are that this is a spectrum of injury, like we said. There lacks consensus in that important or very common middle area. Treatment has an unclear impact on outcome, but there are potential benefits of surgery. Evidence-based treatment in pelvises overall is still in its infancy, and I think we're going to see lots of major studies published in the next 5 to 10 years. With that in mind, Mr. Bates could speak to this better than I could, but there are several RCTs looking at lateral compression pelvic fractures, which hopefully will have data in this area in the coming years. The first is the life study looking at patients older than 60 who failed to mobilize in the first 72 hours. They're randomly allocated to surgical treatment or non-surgical treatment with quality of life and cost effectiveness as the primary outcome measures. And the TULIP study is looking at adult patients with non-fragility fractures and complete sacral fractures, similarly surgical versus non-surgical treatment, looking at functional outcome and cost effectiveness. So targeted really at that gray area, middle group of patients. So more to come in this area. Well, thanks for your attention. And I'll finish with a blatant plug for any trainees online here for our trauma fellowship program and what, of course, we think is the most beautiful city in the world. So if anyone's looking for information, please email me. Thanks.
That's awesome, Kelly. Thanks very much. Great job. Okay, so I'm going to hit you. One of the killer conundrums in the LC-1 arena is the scenario is it's a high energy LC-1, so someone's come off their motorbike or whatever, and they're going to the operating room to have their proximal humerus fixed anyway. Now, this was an LC-1 that you probably, under normal circumstances, would have treated non-operatively, but they're going to the OR anyway to have some other thing, their radial head done or their some other thing. Does that change your position at all?
Oh, I think so for sure. I mean, if you look at that patient overall, if they've got a high energy LC-1, no matter what we tell them to do, they're going to have difficulty weight bearing substantially on that side. So if they've also got an upper extremity injury, then that's an added complexity to their mobility. So absolutely, that would be enough to push me over towards fixing it surgically to try to facilitate their mobilization.
And would you go for a cheeky EUA just out of interest at that point? Would that influence your decision making, or have you kind of made up your mind before you go in?
I've made up my mind before I go in, but I do find EUA can provide some interesting additional information, like might influence whether you're willing to let the patient weight bear after fixation if you think they're dramatically unstable. So I think it's interesting. Like, I think that EUA information is additional information about the patient's stability, but I think we're not at the stage where we can really responsibly apply and measure specific cutoffs to determine if patients should be treated surgically.
Yeah. Mez, can you hit me with a bit of what do LC-1s get in Bristol?
They'd be part of the TULIP study. No. No. So you know, I agree with Kelly. I think it's difficult, isn't it, when you've got a patient who's got 2 or 3 injuries and you're taking them to theatre for other injuries to say that the pelvic ring should be treated non-operatively because it's the ideal opportunity to do something about it. I think the real so if they were polytraumatized and they weren't part of a trial, we would probably have a low threshold for fixing them. Certainly, as Kelly said, if they've got upper limb injuries or lower limb injuries, doesn't really matter. I think it just helps their rehabilitation. I think talking about screening and EUA, I think where it's really, really useful is picking up the LC-3s. So those who have a contralateral external rotation type injuries. And I think these can be missed. So I think it's really important to be vigilant about those. Yeah,
totally agree with that. Paul, there's quite a few questions around the elderly, the fragility, if you like, LC-1. What's your take on those? What would drive you to be fixing an LC-1 or a minimally displaced LC-2 in an older patient, fall from standing height?
Yeah. Well, I think Kelly's talks highlighted that it's a pretty confusing area, really, right? And there is no clarity. And so my personal practice is that I want to fix the ones that have that complete sacral fracture. They're the group that I kind of subcategorize, and they're the ones that I'd be tending to go towards being more aggressive. And I'd also have an eye on the anterior ring and the extent of the injury pattern you're seeing there. And I think that when you're seeing bilateral pubic rami fractures, again, it's a subgroup that you're just thinking there's more of a probability of a bit more instability here is likely to compromise their overall ability to get up and mobilize. And then there's those that don't progress. And so the trial of conservative management and then a few days, let you know, if you're really feeling and it's pain and a clinical assessment, I think is helpful for this, then they're the ones I want to fix.
Yeah. Can I ask you guys about, there's always questions about weight bearing. We've got a couple of those going on from Vishai. So let's say you've taken an LC-1 to theatre, to the OR, and you fixed it. Are we all agreed that that's getting immediate weight bearing is tolerated?
I think the only setting in which that would not be the case is in the highest energy, you know, why Adam Starr wanted to do that study about the spectrum of injuries is he's a believer that there's often misclassification between vertical shear and high energy LC-1. So if there's any question that the patient is vertically unstable, it's in that energy area, then I would say no. But if the diagnosis is really clear and the fixation is strong, I think patients do an excellent job of limiting themselves. Yep. So if they're in too much pain, they're going to be offloading more. So I let them weight bear.
So just pick you up on that. So Mez mentioned about LC-3s. So that's a reason to EUA. If you're worried it might be an LC-3 masquerading as an LC-1, then that's a good, looking down the sacroiliac joint on the other side is helpful. How do you differentiate a nasty LC-1 from a vertical shear?
So I think there's real life and then there's research quality, and those are kind of two different things. I think that with EUA, we can make broad determinations, like the patient has an SI joint that opens on the other side or not. I think that's a different thing than being able to measure millimeters. I think the same thing can be said about vertical shear. If you hold the patient's contralateral pelvis and load and counterload their leg, you can see if there's substantial vertical translation.
Yeah.
But I think you protect yourself from really needing to know that in the highest energy ones if you fix them properly. So they've got anterior ring fixation and ideally 2 points of posterior ring fixation, and make them non-weight bearing. Yeah. Treatment's the same.
Mez, anything to add to that?
No, I think I'm, going back to your first question regarding mobilization. So if I was going to take an LC-1 fracture and stabilize it, I would stabilize the back and the front. And once I've done that, I agree, I would let them weight bear as tolerated.